Good afternoon, everyone. Welcome to the webinar on supporting your perinatal units during COVID-19 evolving guidance. Okay, I think we will go ahead and get started. I'm going to turn it over for introductions to Courtney Nesbitt. Courtney?
Good afternoon. Thank you, Valerie. Hello, everybody. We welcome you today for our 5th webinar in our COVID webinar series. Today, we will be discussing evolving guidance in supporting your perinatal units during COVID-19. This webinar is co-hosted by CMQCC and CPQCC. I am Courtney Nesbitt, Associate Director of Quality for CPQCC. We hope that you are all well, and our hearts go out to all of our colleagues, friends, patients, and families in Northern California who are being greatly challenged with the fires. Stay strong and know that we are here for you all. It's been a few months since we've last connected with our webinar series, and we are thrilled to gather with you virtually once again today. We truly appreciate your continued efforts to support the mothers and babies throughout the state of California and beyond. Thank you for attending today's webinar. Next slide, please. Just going to go over a few webinar logistics. Please note that all attendees are automatically muted upon entry. The chat function has been disabled, but if you're having technical difficulties, please utilize the Q&A box and also utilize that Q&A box to submit any questions you have for the presenters. We will be selecting a select number of questions relevant to the topics presented during the Q&A portion of the webinar, and the remainder of the questions may be used to inform the topics of our future webinars in this series. The slides in the webinar recording will be made available on our resource site shortly after the webinar. Due to the rapidly changing guidelines around COVID-19, the slides and recording may be taken down after 2 weeks. Next slide, please. Just to note that the information today shared in this webinar series and on our resource site serve as examples of how hospitals, healthcare workers, and families in California are responding to COVID-19. We understand that each hospital is working with a different set of resources and constraints, and that some of these recommendations presented may not apply to your hospital setting. Guidelines and recommendations should be adapted to fit your local needs. And also, as this is a rapidly evolving public health situation, we encourage you to consider the most recently available local health department and CDC guidance when developing your internal protocols. Next slide, please. Now, I would like to present our fabulous team today from throughout the state of California. We have perinatal clinicians from UCSD, Sutter Modesto, and North Bay to present their experience around various patient care topics related to COVID-19 as it relates to their clinical practice. Here are today's presenters listed on the slide, and we are so grateful and thankful to each and every one of these folks for their support of this webinar and for sharing their experiences with COVID-19. As a reminder, we will close out the webinar as time allows with Q&A session. I'd like to recognize our physician leaders at our California Quality Collaborative. Dr. Elliot Main is the Medical Director of CMQCC, and Dr. Henry Lee is the Chief Medical Officer of CPQCC. Next slide, please. We will start with the California COVID-19 update, and now I'd like to turn it over to Dr. Elliot Main from CMQCC. Elliot?
Thanks, Courtney, and welcome everyone. If we could start with the next slide. I'm going to start presenting data overall for the course of the disease in California, and then talk about what we've learned in terms of the numbers of obstetric patients infected. There are two sources of data. One is data reported to public health departments for cases and deaths, and the other is hospital level reporting, which also goes through the state, but that measures actually hospitalized patients and ICU admissions. And they tell a little different story. So first, let's look at the left-hand panel, which is as of June, in the middle of what we thought was perhaps the peak, where it was still rising gradually, but the deaths were flat. On the right-hand panel, the story is very different as we get into August. And in fact, the entire left-hand panel as of June fits into the red box. And you can see that actually was a pretty low rate, and then it took off in July into August. The same thing happened with deaths, though not nearly to the same degree. And this has been a national phenomenon, as is that the death rate per case is actually lower than earlier in the epidemic, as we've learned what to do. And there may be some evolution in the disease as well. Next, you see this peak on the next slide. See this peak on the right-hand notch on the right-hand top piece. And that was the server failure that got big into the news, where there are 300,000 test results that were delayed from being reported. However, there may be some positivity, as you see in the last few days, that there's a downward trend, but we have seen cases fall and then rise again, so it's not for sure, but we also see a little tail off on deaths. But when you look at the hospital level data, next slide, this is from the CDPH website, and these are 4 Southern California counties, and the top panels here are all the number of patients hospitalized who are COVID positive. And you can see in each of these counties, Los Angeles, San Diego, San Bernardino, and Orange County, it's trailing down. So this is a bit of good news. And they're all going in the same direction. And the ICU admissions are down. In San Diego County, they're way down. San Bernardino County, which was a big late rise, is also on the downward trend, as is Orange County. Orange County really peaked as you look at this time period on Memorial Day. That's this inflection point as you remember the television stories. What's new in the last 2 weeks, the next slide, is the Central Valley. And here are 4 key counties in the Central Valley: Fresno, Stanislaus, San Joaquin, and Sacramento, showing this big rise in July. And they haven't really started to come down, at least in some of the counties, they're flat. Sacramento County, which had almost no disease early in the course, now is one of the hotter spots, not temperature-wise, but the hottest spot COVID-wise in the state. The other thing to consider is the very bottom panel. This is the number of ICU available beds. And if you remember in the last slide that the big counties in the south had 200-300 available beds, things are getting tight in the Central Valley. Stanislaus County was reporting they only had 8 open ICU beds as of yesterday. San Joaquin had 22, Fresno at 11, Sacramento a little bit more open at 100, but this is something the state pays a lot of attention to as they look toward allocation of resources. So this is general population numbers. There is no formal data here in California or in the nation for sick mothers. Next slide. Before we go there, this is the deaths and the positive cases by race. So we all know the inequities of this disease, and this brings it home to California. Black women are 6% of the population, represent 8% of the deaths. Actually, a month and a half ago, it was up to 10% of the deaths, but it has come down. What has gone up instead is Latino infection and Latino deaths. 39% of the population in California, 59% of the cases in California are the Latinx populations. This is all adults now, and 48% of the deaths. So almost half the deaths in California are the Latinx population out of 39% of the population. Next slide is because we didn't have any data for obstetric populations, we put together a working group with leaders from the major health systems, Kaiser's, Sharp, Sutter, Scripps, Dignity, et cetera, Providence, Adventist, and Cedars, as well as university leads from all the universities in the state, the UC, Stanford Loma Linda, and the 2 big county hospital systems, Santa Clara and Los Angeles. And we were meeting weekly and then bi-weekly, sharing what we knew about our cases, and most importantly, next slide, about the what we're seeing in terms of asymptomatic positives. And the good news early in May through early June was that the rates of asymptomatic positives were actually quite low. 1% or less, often very low throughout the state, with a few hospitals in the Bay Area up to 3%. Southern California had very few cases, and Central Valley had almost none. ICU admissions for obstetric patients were still a couple of handfuls in our areas, and very few in the Central Valley at this point in time. Next slide shows the next month. A little higher in the Bay Area, with people starting to notice that the Latinx population was now starting to dominate the population being admitted to hospitals. A few more ICU cases, but not a big number compared to all the ICU admissions for adults. Now Southern California is rising, but this is nowhere near the rate that was seen in New York City or New Jersey, where the asymptomatic positive rates were 30% in some of the big hospitals there. So this being that percent in the Central Valley was still low. But then in July to August, next slide, we see a further change. Again, Bay Area is stable, but now it seems that 70% of the patients admitted are Latinas. Southern California is a tale of two populations. The hospitals that take care of wealthier patients, it had very low rates. The county hospitals had very high rates, 10% asymptomatic positives versus very few to under 0.5%. Now the Central Valley was all of a sudden getting into large numbers, 4 to 8% positives, as you saw in the general population slide. A few more ICU cases, but we have not had a large number of ICUs, and even the women on ECMO have gotten off of ECMO by and large. The state is aware of 3 maternal deaths from COVID-19. We've reported 3 or 4 deaths. We're not sure if they're the same mothers in either of those reporting deals, but it's very different from H1N1 in terms of severity of mother's illness. So next slide, I'm going to turn it over now to Dr. Altman and Ms. Elvy from Modesto. Thank you.
Thanks, Elliot. And we're going to talk about our experience. Talk about our experience in Modesto and really in the Central Valley. So at Memorial in Modesto, we deliver about 135 babies a month and have an additional 250 outpatient visits a month, and really didn't have any COVID cases until we hit late June, early July. And since then, we've had 14 patients with COVID-19, 8 of them symptomatic and 6 asymptomatic. 8 of those patients delivered vaginally, 6 by C-section. There was really no relationship between the infection and the mode of delivery. They just, the patients who needed C-sections needed them for other obstetrical reasons. And we've kept a close watch on our other quality metrics, and they really haven't changed any in terms of NTSV, C-section rates, and things like that. Since late June, we've seen about 1 to 2 positive patients come into the hospital on a weekly basis. Next slide. So our rapid tests, initially we didn't have any testing, and then the testing was up to a week or more to get back. And finally, late April, early May, we got our rapid tests, which come back typically in 30 to 60 minutes from the time that we send the test, depending on how busy the rest of the hospital is. All of our staff and patients and their support individuals all need to be masked. We have 1 support person allowed into a room. We encourage the patient and the support person to stay in the room. And we don't generally allow change outs of support people, but we will on a very select basis, depending on the circumstances. In terms of outpatients, when they come in for, say, an NST or rule out labor, we don't test for COVID at that point in time. We wait until the patient's being admitted unless they are symptomatic. And now we're testing them for symptoms reasons as opposed to because we're dealing with an obstetrics patient. And for our outpatients, they are not allowed to have any visitors with them. So till we've decided they're being admitted, we have no visitors allowed. In terms of the hospital triage for rapid testing, all of our OB admissions, regardless of whether it's for a scheduled C-section or an induction or for labor, they're all tested. The rapid tests are performed on arrival. Again, we get results back. Typically, it's been within an hour. And then it has been helpful for us in terms of our PPE to know which of our patients are positive or not. It may come up when we do have a positive patient. We are not testing the partners, even though we do know that there's a higher likelihood that that partner will be positive, but that's not something we have started to do. Next slide.
Okay, so in our staffing, basically we decided pretty early on that we needed to designate a COVID designated labor room. So we did designate that. We chose a negative pressure room for both our postpartum area and our labor and delivery area. Obviously, if we get more than one, then the next step would be that we get a private room that we try to have a humid air handler in there to help us. But we overall use the negative pressure rooms. We also identified an OR room. We actually chose a main OR due to the setup that we have in our current family birth center. It is upstairs, so it's different than what we currently deal with, and it had to do with the positive airflow and what we had in our room. So we had to kind of think outside the box as far as that was concerned. We have had 2 patients admitted to our ICU. So to do that, we had to collaborate with the ICU staff as well. We take our electronic fetal monitor machine up there. It does stay up in the room. We have an LNDRN go up, and it's basically a 2-to-1 care between our COVID positive mothers with a collaboration between ICU as well as our labor and delivery nurse. So the COVID positive moms for staffing purposes are all 1-to-1, basically based on the PPE. On our regular COVID floors that are not obstetric, that is not the case. But in labor and delivery, we have kept those 1-on-1 just due to the nature of what they're caring for. Once the mother and the baby are together, we have a COVID couplet, and it requires 2 nurses. And the reason why is the baby is PUI or a person under investigation, and our mother is positive. So we have 1 person that cares for the mother, and the 1 person cares for the baby until one or the other converts. Next slide. As well as we had to do a lot of preparation and training, as I'm sure everybody's used to. We are lucky here at Sutter. We have an emergency management system. That's what the SHIMS stands for, Sutter Health Emergency Management. We do have clinical advisory groups that have gotten together for the different body systems, right? So the obstetrical clinical advisory held regular calls. I still sit on those twice a week. We have email updates that go out to all the staff as well as leadership. Sometimes those are the same, sometimes they differ. We have a thing here at Sutter called a no-do share. It's a very SBAR formatted memo that goes out to all staff across the system that tells us what we're doing, and those come from those clinical advisory guidance. And they're very detailed workflows. They're algorithms that they can follow. Those have changed, as we all know, as we've learned. So that comes out quite frequently. One of the things we did have to do here in California due to the surge, I am working in the Stanislaus County, the Central Valley that he spoke of earlier. So we did have to cancel the time off for my staff. That happened across in several different Sutters, especially here in the Valley. So one thing to consider is the staff just couldn't take their PTO, which has been quite devastating. And we're just now starting to institute that again. Sorry, I was getting ahead of myself. We also had to do a lot of training and preparation in March and April on PPE, don and doffing. Obviously in labor and delivery, that's not something that they're as used to doing. So there was a lot of training and a lot of reinforcement, including in the beginning, we had people that would float down and monitor the don and doffing to make sure. So we had a spotter. We did that up on our adult floors as well. And finally, one of our preparations was simulations. We started with tabletop, sitting around talking, and then we're now transitioned to traditional simulation with COVID patient scenarios. Next slide. So some things to consider with staffing is that it took a lot of rounding and a lot of talking, as our labor and delivery nurses were highly specialized. I come from a hurricane area, so I was more used to that type of disaster. The pandemic was a little new. It's new to all of us across the country. Definitely new to the staff in our labor and delivery department. So what I had to make sure they understood was there's no close equivalent. In the hospital for the adult care, we were training people to become ICU nurses. We were doing lots of training across the hospital for the surge. Labor and delivery did not have that, right? So because the hospital, we had nursing shortages as everyone else, and the traveler resources are scarce because when our surge came, so did Florida, so did Texas, and across the country. So the travelers were being pulled everywhere. So that created us to really think, how are we going to maximize the resources we had on hand? So we assessed our hospital employee resources. We looked within our maternal health service line. I was able to locate some nurses that were formerly labor and delivery nurses. So we pulled them back in to get them reacclimated to what they did previously, as well as going through our roster inside the hospital and finding employees that had experience in our labor and delivery areas. And that was where we got lucky and pulled a few people in that way. Next slide. And finally, one of the things that was most important, and that has and continues to be most important, is our support of our staff. As I mentioned, we had to cancel vacations to make sure we could take care of the volume that was coming in. So we had frequent meetings with staff around morale building that would be in person, rounding, and or over the phone, having remote meetings, much like we're doing now. It required frequent leader rounding. I round once a day. The managers round once a day, and senior leadership rounds quite frequently, at least once a week. Additionally, what was really important is rounding on our physicians. The physicians come from different groups, and it was really important to hear they all had different concerns, different needs, and they changed rapidly depending on the information that was coming out from all the peers. We also had bi-weekly physician focus phone conferences, meaning they would call in and I'd hold a meeting to make sure that they also knew what was coming out of our SHIMS conferences. And what I found was most important was acknowledging the fear, really facing that head on. These nurses are scared to death, and especially once we started getting our positive COVID mothers. We spent March and April pretty much assuming it wasn't going to touch, or the nurses did. There was a false security. And then we started getting our positive mothers, and they realized this wasn't just for adult medical surgical. This was going to affect us in our service line. So the final thing was, and I just did it yesterday, is constant and consistent encouragement of our safety measures. Meaning just like the rest of the country and what we see on TV every day, there's different levels of compliance, even with the medical staff. Staff trying to go on vacations and traveling and social visits, and we're constantly fighting that. So it's constantly reinforcing the message from the CDC, from our peers and the experts about what is causing the spread and what surge comes from. So that's been a challenge. Next slide.
So things that we've learned, for a little while, as we were just dealing with the surge, and then we were beginning to make sure we understood how to take care of our COVID patients. We didn't want to lose track of our other simulations: postpartum hemorrhage, preeclampsia, cardiac arrests in moms. And so we restarted all of those in a way that we felt like we safely could, and still doing our sims. We also had some difficulty at the beginning in trying to decide whether or not did doulas count as part of the caregiving team, or were doulas visitors. And say doulas were initially for us excluded, sadly, from helping moms through their labors. And we've since managed to come through that. And so doulas are now, again, recognized as members of the caregiving team and are allowed in addition to the mom's partner. We had to look at PPE needs, how many we needed. We had to really organize that PPE well, because sometimes you need it in a hurry, and making sure that you can grab the right mask at the right time without having to search for it was important. And so we got creative, and using a little bit of lean management, got our PPE all organized and cleaned up. And again, it's important not to forget all of the other key quality measures that we always need to be focused on. We are dealing with a pandemic, but we can't forget the core quality metrics that we all need to continue to stay focused on. Next slide, please.
So as we've come through this, and we're starting to kind of, we've flattened a little bit, but still very high, as you saw on the previous presentation. So some of the challenges we've dealt with, we have a high surrogacy delivery volume here that has been quite challenging, and still thinking outside the box, because more than one person comes, there's a support person and there's the intended family. So we've really navigated that quite gingerly, I should say. Staff fatigue and stress is really starting to show probably everywhere. I'm sure we're not unique to that. And the varied behaviors outside of work. Again, really paying attention as in leadership and when you're supporting your team of paying attention to what people are saying, what they're saying as a team amongst each other, catching who's got what behaviors outside of work, so that you keep your staff safe, because as I told them, once they get sick, there's not a backup. The nursing station has been a challenge with the social distancing. We don't have a large one, and I'm sure we're not unique to that as well. So that requires constant reinforcement and some creativity. Testing changes as we've gone through this pandemic. We went from as everyone else I'm sure did, we went from one type of test that took a few days, and now we're in the rapid test, as Dr. Altman said, that takes anywhere from 30 minutes at most at 2 hours, and that's on a high surge. And the method of collection changed as well, from nasopharyngeal to a swab, and now of course we're hearing of the saliva coming down the pike. The other one we just spoke of was the support person compliance with staying in the room. So that has been an ongoing challenge, and likely again across the country. And it really has to do, in my opinion, with the demographic of where we are, based on people I've talked to across the states. So we've had to deny entrance some. We've had some that came up with all kinds of creative reasons they had to leave the room, and I'm sure you're all used to. So we had to deny entrance, and we had to have them switch out. So like a grandmother would come in instead of the father because they kept leaving, and vice versa. And then finally, it's the patient or support person compliance with masking. So it's constant reinforcement of knocking on the door, I'm coming in, please put your mask on, because you're going to, it represents what's going on in the country, just different levels of understanding of the pandemic and what they're going to do and why they need to wear the mask. Next slide.
So we've included in this slide deck, and just really to make available for you a couple of flow diagrams that we use. We're not going to go over these in detail because they're too hard to read, but they will be included in the packet for afterwards. So it's how do we assess moms who come in labor or who are getting admitted, and what do we do about them when they're positive, as well as the babies. Next slide. And same thing. Again, these will be included later for your review. Next slide.
And this is just an acknowledgement of my team. And now, as you know, it wasn't me, it wasn't Dr. Altman, it took all of us. And they have really put, as you can see the spike, a lot of gratitude goes to the team. Next slide. And with that, I'm going to pass it over to Dr. Ballas. Go for it.
Okay. Am I on? Okay. Hello, everyone. Jerry Ballas from University of California, San Diego, Maternal Fetal Medicine. I'm just going to go over kind of our adjustments we had to make to prenatal care in the age of COVID, as well as how we are resuming care for women that have tested positive. So as you can see on this slide, a quick overview of our system. We do approximately 3,500 deliveries annually between 2 hospitals. We have the Newer Jacobs Medical Center up in La Jolla. That's the big blue star in the north there. And then UCSD Hillcrest is our classic county hospital we've had for decades. It's ramping up its delivery services once again, and does a fair proportion of deliveries these days. We are a mixture of private, public funded patients. We have clinics throughout the county from north to south. And we have a variety of practitioners, from generalists, hospitalists, residents, fellows, midwives, advanced practitioners. So we had quite the system to manage, especially when it came to prenatal care. Next slide. This is just a quick kind of current snapshot of where we stand with the positivity rate and the cases per 100,000 in the county. We're actually on a good trajectory, which those of us with young children, like my kindergartner, we are excited about, because we are below the 100 per 100,000 case rate currently. So we, in general in San Diego, and you'll see on the next slide, we have a surge, but we have managed to stay pretty much under control to some extent, and I'll go through some details here. So we have in late February, just as a little timeline, late February, early March, next slide, first bullet, we started getting the repatriated citizens were sent to our local military bases. These are the folks you heard from, like Princess Cruise Lines and across returning from international travel. And then we started getting our first reports of community spread. And then next, in mid-March is where we started seeing our screening and social distancing in patient care areas was started within our clinics and our labor and delivery units. We started enforcing many of the visitor policies that were just spoken about, and then converting our clinic visits to telehealth, and I'll spend a good part of my time talking about that. And then March 31st, actually our first COVID positive OB patient was flown in for ICU care, and I had the lucky privilege of being on call that night for her. And then our last bullet point is in early April is when we started our routine screening for L&D patients, and testing became more widely available in various forms as was previously discussed. Next slide. And then there you see right about there in the course of the pandemic is where I was asked to present a plan to incorporate telemedicine for our prenatal care practice. So pretty early on, and we were doing pretty well in terms of county-wide presence of the disease. Next slide. So this is a presentation actually taken from what I spoke to our faculty about in terms of motivating for telemedicine during prenatal care. We did not really have much of a presence at all of telemedicine within our prenatal care space. Like I mentioned before, we have a wide variety of care models from midwife care, low risk, all the way through primary prenatal care done by maternal fetal medicine. So you have the entire spectrum of how frequently patients need to be seen. So basically to motivate folks, we started with this increasing restrictions. We need to promote social distancing. Every patient needs to be prepared to have an increasing number of visits go virtual. Adjusting our own comfort level with virtual interaction because the risk of exposure for us, our patients, and our staff was growing exponentially at that point. And referring providers have to be made aware that some of our consults may be performed virtually so they can actually prepare the patient. Next slide. So I frame this also, for short-term goals, social distancing for patients, faculty, and staff. Attempt to decrease in-person clinic volume by about 50% was our ambitious goal initially. We wanted to leverage the technology, maintain the highest level of care while minimizing the financial losses from fallow sessions, and also educate patients to be more vigilant and involved in their own care. And then to frame it as next slide, more long-term goals for telemedicine, kind of pitched to the department of increasing access throughout the region, minimizing costs and inconvenience across the course of a pregnancy for women, and to improve marketability for increasing virtually oriented population, which we're starting to see now is starting to become more and more part of medical care. Next slide. So I took this example from the Kaiser Family Foundation website. It's by no means the only way to skin a cat, but this is one way to visualize kind of how we perform our traditional inpatient prenatal care, and kind of an outline of times in gestation where you can think about maybe switching to a virtual visit rather than having the patient come in. And of course, you have to acknowledge some of the challenges that come along, which includes having to monitor things like blood pressure, having physical exam for some of our early screenings for things like preeclampsia and high blood pressure in pregnancy. Who can conduct the telemedicine visits and how to conduct them became a big part of our questions. And then, really coming with the data that shows that you can safely implement telemedicine into your practice without compromising safety, especially in low risk and uncomplicated pregnancies. Next slide. So this is how I outlined within our kind of looking at that picture in a different way in the way we conducted our typical visits. And so this was just an outline for providers to kind of outline how they feel they could transfer some of the practices into telemedicine visits. So the first column is where we would have inpatient. The middle is where we're lucky here in our system is that all our ultrasounds are read within our perinatal and maternal fetal medicine units. So that's an opportunity, again, to interact with a physician and have some portion of prenatal care conducted. And then on the last column is suggestions for what can be turned into a telemedicine visit. Now, ultrasound antenatal testing appointments also serving as intentional contact, as I mentioned. And we had a plan in place to record weights and blood pressures at those appointments in order to facilitate some of the screening that's missed from an inpatient perspective or in-person perspective. Now, again, we always had to say this is a guide. Like I said, we had the full spectrum of low risk to high risk pregnancy. So, and we had a full spectrum of practitioners in terms of comfort level with telemedicine and in-person visits. And so we had to be cognizant of not trying to make a rigid outline and more of a suggestion. And we had to acknowledge that there could be risk of a certain risk taken to high-risk pregnancies, especially in terms of lack of screening for high blood pressure, fetal well-being, in order to benefit from greater social distancing. Next slide. So this is just an overview of some of the uptake that occurred over time once we started our initiative. So this was from mid-March through this past week. And you can see the third column that is the MyChart video visit. So we have Epic, we have MyChart available to patients, and our video portal would go through MyChart. And what was interesting, if you click to the next graphic, I kind of superimposed that third column with the county case rate. And we really did have very quick uptake. Our providers were very flexible, our patients were very flexible, and we did a great job increasing our telemedicine capabilities early on. And as we incorporated greater social distancing rules, masking, testing, and felt more reassured within the clinic, we slowly were increasing our in-person visits, even in the face of that increase in case rates throughout the county. And we still have not seen any huge effect on our staff or our providers in terms of contracting COVID-19 from the community. So I think that says a lot to the combination of early acknowledgement and then ongoing preventive measures done in the clinic. So next slide. So here you see we had, our highest rate was 31%, fell a little short than the 50% hope to change our visits, but we did hit that high in April. And then our current rate, like I said, has come down almost to 9% now. The largest drop in clinic visits, about 30%. And now we are actually almost 103% of our pre-COVID volume in terms of in-person clinic. And then specifically for maternal fetal medicine or prenatal imaging and antenatal testing volume, we were able to decrease spread out testing, spread out studies, and decrease our census modestly. And now we are currently back to pretty much pre-COVID volume. Next slide. And so some of the challenges, you know, both perceived as well as encountered. So the biggest challenge we thought we were going to have was technology-based, language-based, health literacy amongst our patients. There were definitely some patients, and I think that can be said with any form of care, could be an issue, but specifically, we were pleasantly surprised at the willingness and uptake for virtual visits amongst many of our patients, especially our lower income patients that, you know, traditionally folks have that misconception that they're just not going to be able to connect virtually or not have the technology. Once you took the time at a visit to really teach them, it was amazing how many were able to just pick it up on the fly. And then, of course, the high-risk conditions necessitating closer monitoring. This was what made a lot of our high-risk providers a little on edge, especially towards the end of high-risk pregnancies in terms of monitoring maternal and fetal well-being. Provider uptake. Now, this comes along with, you know, practitioners that have been practicing for a long time, younger practitioners. Comfort with remote assessment was key. Incorporating it into your daily schedule was another huge question mark. Whether to make entire sessions telemedicine, do you incorporate it into your live sessions? So that was always a challenge. Then, of course, billing, which I'll give credit to a lot of the federal and state billers that were quick to adapt and quick to accept more billing for telemedicine, telephone visits, and understanding that we needed to really reassure our providers that there wasn't going to be a sudden huge windfall in terms of income. And then institutional, I give UCSD credit in terms of upping the availability of technology and making it very easy to bring it into your clinic and have a lot of available IT support. And then the ability to convert same-day visits to our evaluations if concerns arise didn't become too much of an issue, but was always kind of hanging over our heads. So next slide. So as we've gotten deeper into the pandemic, and as you saw the surge later on in the cases, we are dealing more and more with patients that tested positive, have recovered, and are now resuming prenatal care. And so for guidance to resume prenatal care, we look mainly to the CDC, kind of modifying a lot of their guidance for ending home isolation. So next slide. The first step really was, now that we had enough cases worldwide, nationally, where we were able to start identifying mild, moderate, and severe cases, we adopted the CDC's guidelines for labeling such cases. And that helps with us going forward in terms of comfort level in resuming prenatal care. So I won't go through the slide in detail. This is available from the CDC, but these are the criteria for defining mild, moderate, and severe. And then there's some special considerations below for the immunocompromised patients. And so next slide. This is specifically presented to our staff, modified from the CDC guidelines in terms of symptom-based strategies for discontinuing transmission-based precautions isolation. So this is the general guidelines that the CDC puts out for patients to be off of home isolation based on their symptoms, severity, and so forth. And again, this will be available to you to read out, but these are modified from the latest CDC guidelines for ending home isolation. Next slide. And so specifically for in-person prenatal care, this is what was also presented to our staff and our MAs, our nurses, our sonographers, for them to use as a reference if they ever see in their chart a patient coming in that they are labeled COVID positive. They're able to see what category they fall into and make sure that they're appropriate to come in. Now, hopefully we've taken a lot of that off their hands by having our COVID nurses and follow-up clinic screen these patients in advance. And so you see from the asymptomatic and non-severely immunocompromised, obviously at home isolation, all of these folks get sent to our COVID nurse line for routine daily assessment for symptoms. And if symptoms do develop, they're referred to our ID clinic. And so you see if greater than 10 days from a positive PCR and they stay asymptomatic, they're able to resume ambulatory care. We typically do an MFM telehealth consult just to kind of cross our T's, dot our I's. We follow up growth ultrasound, BPPs, depending on gestational age, and then antenatal testing if there are other indications that warrant, not strictly for a positive test without symptoms. And then we do obtain blood work once they're able to present for inpatient care in labs. And then we progress from mild to moderate illness without immune compromise. We do the home isolation. What changes that our ID clinic becomes involved in all these symptomatic cases. And then you see the bottom is pretty straightforward as well. Refer for consult when it's greater than 10 days from onset of symptoms, 24 hours without having a fever, without medication, and improvement of symptoms. And then the severe to critical illness, they tend to be more case-to-case basis. These are folks that maybe were intubated at one point, recovered, are now home. And so we have the more stringent guidelines you can see in that column. You can go to the next slide. And these are the special considerations. And so, you know, there's situations where if a patient needs something or has an obstetrical complaint prior to being able to be cleared for in-person visits, then we have them seen in our hospital triage. And that goes through the L&D charge nurse is notified, our whole screening system downstairs is notified, and these folks are brought in kind of in a very regimented way to minimize exposure, and they're brought to our triage room in a negative pressure room and evaluated. We do not routinely do repeat PCR testing at this point as recommended by the CDC. If there's somebody with either continuous symptoms or concerning symptoms, we usually will defer to ID in terms of repeat testing. But in general, we do follow the symptoms-based guidance for resuming prenatal care. We have a birth center, a very active birth center. Anybody COVID positive, we tend to make them not a candidate for the birth center. Any ongoing symptoms, they qualify for prenatal care, need antenatal testing. We assure that the appropriate distancing for NSTs, and we do single occupancy rooms. Placentas go to pathology, and then here in California and nationwide, we recommend everybody join the priority study that's had a positive diagnosis. Okay. And here we go for lessons learned. So like I mentioned before, patients are adaptable. If you're upfront direct, they understand they're all living through the pandemic as well. So don't assume too much. Take time to introduce the new technology. So we actually will have time in our clinic to show them. I lost you. There you go. And then be flexible. And I say sense of humor. I mean, everybody, there's an adjustment period to seeing your doctor, seeing your patient in their home environment sometimes, or seeing yourself on a screen. So taking the edge off and not making it completely awkward does help with these interactions. I learned that physicians and administrators can be least adaptable. So you do have to identify your champions amongst your faculty. And if you are lucky enough to have either a young cohort or trainees like we do at UCSD, recruit them. They tend to be the most pliable and most enthusiastic for adopting new technology. And then alleviating the anxiety about billing, technology, and liability, I think is a huge support from administration. And then all staff members, you know, don't forget your sonographers, your MAs, your nurses, everybody who's involved in the complete chain of patient care in order to make sure the protocols are clear and you've answered all their questions and alleviated concerns as previously mentioned. That's a hugely important part of this. Next slide. Creating telemedicine only sessions is what I would recommend. Interspersing with in-person visits is a little awkward. It's inefficient. So you can create a workflow that actually includes your front desk assistants, nurses, and provider in one concrete session or one concrete template to make things flow a lot easier. And then fatigue is inevitable. You know, as with the quarantine, as mentioned in the previous presentation, providers simply want to go back to normal. And that includes, you know, with prenatal care. And so we have to keep reinforcing the importance of social distancing, and I think reinforcing the benefits of virtual care if possible. And then having a new long-term vision for a paradigm. And then investing in technology, I think, is huge going forward across all branches of industry. And I think the medical industry is ripe for the picking for telemedicine at this point. And that's the night of the first COVID patient. So I'm going to hand it over to Jenny Quinn from North Bay for the continued presentation.
Hey everyone, I'm Jenny Quinn, a neonatal nurse practitioner at North Bay Medical Center. My discussion is going to primarily focus on our current labor and delivery process, and then really the management of the newborn and our process currently in the NICU. So Fairfield is located between San Francisco and Sacramento along Interstate 80 corridor. Fairfield is home to Travis Air Force Base and a Jelly Belly factory. So if anyone wants to come on out and visit after the fires are finished, please look me up. We'd love to have you out here for a visit to our department. Next slide, please. North Bay is usually situated under a bright blue sky. However, with the recent fires, the scene has certainly changed for us. The picture on the top right, I took on Wednesday as I was driving to work. And as you can see, the smoke is just filling the air, ash was falling. And then this picture on the bottom, I took from our back parking lot. And you can see a fire burning in a local hillside in Fairfield. So our community is one of many in Northern California dealing with the fires, smoke, and evacuation orders. And I just want to give a big shout out to our local first responders and fire personnel. Next slide. So North Bay Medical Center is Solano County's community hospital. It opened back in 1959. We have a 16-bed community level 3 NICU. It is an open bay. We have one isolation room. We have an overflow room that we have discussed would be utilized to cohort COVID or PUI cases. Currently, our average daily census is roughly around 8 patients. Next slide. Last year, we had a little over 1,100 deliveries. Our group is a private neonatology pediatric group. We have 3 full-time neonatologists, myself, a pediatrician, a per diem neonatologist, and we're contracted with North Bay Healthcare and another local level 1 nursery in the area. Next slide. So in regards to the process at our hospital, all staff are wearing surgical masks when they're inside the hospital. Those working in high-risk areas such as the emergency department and the adult ICU, or performing aerosol generating procedures, they are wearing goggles. And it has recently come down from our command center in line with CDPH recommendations that all healthcare professionals should be wearing goggles when they are engaging in direct patient care. So patients and a support person, if they are allowed into the hospital, upon entering will get a temperature check, as well as health screening questions are asked and answered. Next slide. We do COVID testing at our urgent care centers, the emergency department, for all admissions, and then pre-procedure. As of last week, we had 8,400 patients and tested 602 positive cases from those that were tested, and that gives us a 7% positivity rate. We have started universal screening or testing in labor and delivery back in June 15th. And then as of last week, we had a total of 218 deliveries, 10 positive cases, and that puts us about a 5% positivity rate last week. All of our moms that have tested positive were asymptomatic. Next slide. So as I just previously mentioned, we are doing universal testing. So admissions are considered PUIs. Nursing staff are in full PPE gear. We get our results in about an hour. Mothers are allowed to bring one support person and a doula if this has been prearranged. We are recommending that the support person is wearing a mask upon entry when staff are entering the room. I can say from personal experience, this is happening maybe 30–40% of the time that staff members are, that the support person is wearing a mask consistently. Next. So for our moms that are testing positive, the father or the support person that's with them is also tested. Early in the pandemic, we did temporarily separate one infant. The father of this child tested negative, and the parents were not living together. They were in a separate household, two separate households. Since then, our care is managed in a couplet care situation. We are not moving these families down to our postpartum floor. They are staying in labor and delivery. All staff entering the room are in full PPE gear. We cluster care when possible. Additionally, we do have this doffing assist, so similar to a previous presentation by our setter colleagues, we do the same thing. So when we are leaving the room, we have a nurse or a staff member that is assisting us in removing our PPE equipment in the proper sequence. We actively promote breastfeeding, and our labor and delivery nurses provide the initial education to our families, such as maintaining 6 feet of separation when not directly taking care of their infant, to wear a mask, and then frequent hand washing. Next slide. The newborn health care provider, so that would be myself or the pediatrician I work opposite of. With our initial assessment, we are reviewing the current recommendations from AAP and CDC, as well as providing our standard discharge teaching to the families. We are also giving the families a couple of handouts that we have pulled from AAP's website. The titles are listed below for your reference. We do cover current CDC recommendations as far as quarantine and home, and then again, just reviewing measures to reduce the spread of the virus. It's been my personal experience that these moms and families really are kind of shocked when they get this positive test, and oftentimes they're kind of questioning how they even got the virus. They're indicating that, they're not leaving the house. Many of our positive cases are from our Hispanic Latino communities, and they are essential workers. So when we had our surge in our county recently, back in June and July as well, a lot of those were coming from our essential workers in our community. The newborns are tested at 24 and 48 hours if they are still in the hospital at 48 hours. And should the parents consent to it, we are doing circumcisions in the room. Next slide. So our follow-up for newborns is scheduled as usual. We haven't changed this process other than notifying the outpatient clinic of mom's positive coronavirus test. We also offer a service called Pop Clinic at North Bay, or Pediatric Outpatient Clinic. These are weekend appointments. We schedule newborns post-discharge if it's a Friday discharge and the Monday appointment with the outpatient pediatrician is just too far and we're wanting to keep track of something. Additionally, the POP Clinic is open for our community pediatricians to make appointments for infants as well. So we assess things such as belly checks, weight checks, and conduct feeding assessments if that's been requested. Our POP Clinic is managed by a lactation consultant or a nurse working that shift. Next slide. So it was a challenge, certainly for us. We had to quickly kind of develop a protocol on how to bring newborns back for a POP appointment that were born to COVID positive moms. It was essential for us that we maintained our same level of care that we provide to all of our families here at North Bay Medical Center. So this protocol covers our process and how we manage the POP appointments for these newborns. So the families are instructed to drive to a back door in a closed wing in our hospital. They call up to the postpartum floor and let the staff know that they have arrived. The nurse will bring down all the needed supplies specific to that POP appointment. They're in full PPE gear. They conduct their POP appointment, and then the room and supplies are cleaned and sterilized per our COVID cleaning protocol. Next slide. In regards to the NICU, nothing really hasn't changed for us. We have just obviously limited the number of people that we allow into the NICU. So the mother and father of the child or the designated person, so 2 people have access to visiting their newborn infant in the NICU. We offer 24/7 visitation hours. That hasn't changed either. People entering the NICU, families and staff are all wearing surgical masks, as well as conducting the appropriate and frequent hand hygiene or hand washing. Should an infant need to be intubated, either myself or the neonatologist doing the procedure will wear an N95 and eye protection. Next slide. So since the start of us doing universal screening, we've had 2 infants that had to be admitted into the NICU. They were brought into our isolation room and we did our standard testing at 24 and 48 hours of life. Prior to the pandemic, any back transports that we received, they were admitted to and discharged from our isolation room. So this process hasn't changed. Obviously, though, these patients are considered PUIs until we get the COVID test back. Again, this is done on admission and we usually get the results back within an hour. Next slide. So the 2 infants that were born to COVID positive moms, one was a late preterm infant with hypoglycemia. We do glucose gel at North Bay, couldn't manage the hypoglycemia with that nor supplementation, so the baby was admitted for IV management. We also had a term infant with initial and short-term respiratory distress. None of these families were allowed to visit in the NICU. Updates were provided to the families via FaceTime or phone. We also have NICView cameras at all of our bedsides, so families have access to their babies whenever they choose to log in and see their baby by the NICView camera. The term infant was sent out to mom's room on day of life 2, where that child roomed in with mom and for an overnight stay. And then both babies were discharged on day of life 3. Next slide. So in closing, I'd just like to share a story. North Bay has the privilege of offering services and care to our local communities, active duty and military men, women, and their families. And this little girl here, she was born at 32 weeks on July 4th. Her father was deployed in Saudi Arabia, so not only is he dealing with the birth of a premature daughter, he had to travel back to the US, spend some time in quarantine, and then he was able to meet his daughter for the first time when she was about 3 weeks old. So this is another part of, a very important part of our family at North Bay is our military community. So I'm finished with my presentation. Thank you for your attention, and I'm going to send it over to Christina and Courtney to moderate the Q&A session.
Thank you. Thank you, Jenny. This is Christina Oldini. I'm Associate Director at CMQCC, and I'm going to have Courtney start off with a quick question to Jenny.
Jenny, don't turn off your video yet. Great job, though. Thank you. Okay, Jenny, we have a question. If a mom presents with a history of COVID, but is over 10 days out from a positive test, how long should we designate the infant as a PUI? If born preterm, the infant may be on respiratory support, so we can't use a symptom-based approach. Is 10 days post-illness enough?
Yeah, I mean, we would follow the current CDC recommendations, and that's what they're saying at this time, that the most contagious time frame is within the first 10 days. So we would no longer consider a mom to be infectious or contagious following 10 days from the positive test or 10 days from symptoms. So that's also an important distinction. It can't just be the test that we would consider. Again, we in our NICU, we do really well with double CPAP. We have a very low rate of intubation. So should a child develop some sort of respiratory distress, our obvious differential diagnosis is going to be a rule out sepsis. And then I think in light of what is happening currently with the pandemic, certainly more questions would start to be asked regarding current history and current interactions potentially. And we probably would test the infant sooner than later for COVID.
Perfect, thank you. Jerry from UCSD, we're going to throw it to you now. Thanks everyone for coming back on camera. A laboring patient with the history of a positive COVID test in June was followed by a negative test in July. Retested during admission in July, for low-grade temp in labor. That test comes back positive. Is the patient reinfected? What's the science telling us now?
The science in reinfection is still very fresh, very new. And, common sense being that if in labor with low-grade fever is a common things being most common, something related to labor. It is a tough one because, the positivity of the PCRs post infection can be prolonged, as we've learned. That I would say more so that negative test in the middle might have been a kind of a false negative. And then the positive is just a continuation of picking up PCR, because we've had patients for months with getting tested outside with positive PCR and no symptoms. The better part of Valor, the safest thing to do at that point, recommendation-wise, would likely be to implement your PPE protocol for the delivery. I don't think anybody would fault you for kind of treating either the patient as a PUI or a infected patient, given the potential. But we really don't have much data to go on reinfection. The chances are it's low. The chances are it's likely something more related to that labor in particular. But now that PPE is available and we have much more practice with managing labor with PUI and positive patients, the safest thing would be to manage as such.
Got it. Got it. Bob, we're going to go to Sutter again in Modesto, Bob Altman and Tiffany. What about patients who refuse COVID testing as part of a universal screening admission? How should they be treated, positive or negative?
We thankfully haven't had that happen yet, although we've had patients question, whether they should get tested, and finally they agree. We've been treating them as if they were positive. So basically all of the caregivers wearing N95s and the babies treated like a PUI. I think in part for us, it's because, 1 in 20 of our moms, at least the last couple of months, have been positive, symptomatic and asymptomatic. And so that's a high enough rate where we feel like it's reasonable to take those precautions. I think you have to understand your local community prevalence. And if it's extremely low, that may not be necessary. But at 1 in 20 for us, that seems reasonable.
Jerry, do you, in your experience, is that what you guys are you treating folks as positive?
Yeah, I think, again, going to the most safest at this point, we have to realize we are still pretty early in learning about the course of this disease in general. Now, we have had a fairly, on average, low community prevalence in general, but I think that would be the safest way to go is treat as positive. I don't think there's a downside to it, aside from obviously the added kind of stress of the delivery process itself and a few extra steps, but I think that would be the safest for all involved.
Okay.
Yeah, and if we can save, a physician or a nurse from being infected, and even if they, they're reasonably asymptomatic, but need to be quarantined for 2 weeks, we can't afford to lose them for that couple of weeks. We're already down several.
That's right. That's right. I think we're going to begin to close it out here. I hate to do it because we could keep going. Can you do the next slide, Valerie? First of all, we just want to go ahead and thank you, our attendees. This is the 5th webinar in the series, and we also want to recognize all the presenters. Everyone's got a lot going on, and we are so grateful for the time you spent with us today. I'm going to get to the CME info in just a moment here. Again, the information shared in this webinar series and on our resource site, which we'll show you in a sec, serve as examples of how hospitals, healthcare workers, and families are responding. Hospital systems are different. Please continue to go ahead and follow your local health department and CDC guidelines. Next slide. Here's the CME information. We'd like to thank Stanford School of Medicine CMEs for supporting this event. And again, the BRN in the state of California does support CME use for contact hours towards your license. The slides will be up on the website. This is the website, COVID-19 resource site. Please go ahead and check it out. This is curated continually by our leaders and our 2 communication managers. So thank you so much. Thank you so much to the entire teams at CMQCC and CPQCC for working together to really to pull this together in quick fashion. We want to thank everyone for coming today. We want to thank everyone for caring for our patients. So please stay safe and well. Thank you, everybody.
Thank you.
Bye, everyone.